Hi, everybody. I'm Bob Eckel. I'm one of the co-chairs of the Cardiometabolic Health Congress, which meets in Boston annually. And this is our 19th year of having this health congress, and it's great to have you be on board here for our conversation with Dr. Jose Florez. Jose's a longstanding colleague and friend at Harvard Medical School and now has a distinct appointment as chairman of medicine at Massachusetts General Hospital. And I've known Jose really from a wide variety of perspectives, following his science, which I know not enough about, but also when I was president of the American Diabetes Association of Medicine and Science, we kind of started something there when I kind of got involved as a bleacher fan in Precision Diabetes Initiative, which is the ADA-sponsored event that now has continued forward for over 5 years and now is taking on a new life. But anyway, Jose's here because his background is extensive in the genetics of things that relate to diabetes. So Jose, describe yourself in terms of your scientific history and ultimately your transition of roles from being a pure scientist now to being more of an administrator.
Yeah, so scientifically, I am an endocrinologist, an adult endocrinologist. I see patients with diabetes of all kinds. But then I developed a research program in the genetics of diabetes. I lived at a time when the human genome had just been sequenced and it was available for all of us to mine. And over the last decade or so, we discovered many parts of the genome that influence diabetes risk. But as a clinician, my real interest is how does this information going to affect how we practice? Is it going to affect our diagnosis? Is it going to affect our treatment plans? Is it going to affect the prognosis as people have? And so what I devoted my research life, my academic life, was to see whether we can harness the power of the human genome to transform the way we take care of patients with diabetes.
So precision diabetes medicine goes beyond simply the genomics, doesn't it?
Yes, absolutely.
It goes into what you alluded to, the ability to translate basic science information into clinical assessment, diagnostics, and therapeutics to follow. You want to expand that space?
Absolutely. So the way I think of genetics, if you think about genetics, germline genetics, the genetics we inherit from our parents, that's static. That we receive at conception, really, and it is there for our entire life, and it doesn't really move, but it does involve some risk for disease, potentially for response to medications, for the type of diabetes you may have. And then over that, we need to superimpose all the effects of the environment that may have to do with obesity, that may have to do with insulin resistance, that may have to do with diet, exercise, etc. So on a skeleton of genetics, I see that a number of other biomarkers, whether it's blood biomarkers, whether it's epigenetic marks, can also modify this static risk predictor into a richer risk predictor that takes into account the metabolic state of the individual.
So what you're really talking about is a whole field called epigenetics. Is that not, in fact, in part, what you're alluding to?
Epigenetics is one element. So epigenetics is interaction, is the modification of the genome that tells you what genes to turn on and off in specific tissues, at specific developmental stages, in specific metabolic states. So the way the environment and the genome interact is through epigenetic marks. But there may be other things that have to do with the diet that you take that doesn't have an epigenetic effect, but is a transient effect. It could be something that is a little more static, like your obesity risk. So there's a number of other biomarkers that we can incorporate into a genetic scaffolding that then comes up with a better prediction, not only for what's going to happen to you over time, but maybe even the kind of diabetes. Type 2 diabetes is just a glucose-based diagnosis. Diabetes that is not autoimmune, that is non-monogenic, we call type 2. There's many different kinds of type 2 diabetes.
Well, and you're part of a series of papers that have addressed these issues, published in Nature Medicine recently, actually, which have about 50 to 100 authors, many of them, right? So let's outline a study in which you might take people who are at risk for diabetes. Let's call them pre-diabetic, although the term could be argued with an A1C maybe closer to 6.5, maybe in the 6 to 6.5 range. How would you go about choosing biomarkers for such a study to examine maybe the impact of, say, a polygenic risk predictor, multiple genes? And by the way, I'll just comment on the fact it's been a little disappointing that all the genomic information doesn't show us one gene that causes type 2 diabetes.
Right. So it is true that because it's a very complex disease, there's many genetic markers that influence, and each one has a very small effect on overall risk for the general diabetes that we see. So we're not grouping them into polygenic scores, which is an aggregate of genetic predictors, but we want to group them in an intelligent, rational way, in a way in which these genetic predictors are informed by the physiology of the person. It's not only all the genes that cause type 2 diabetes, but genes that are grouped based on whether you have insulin deficiency, insulin resistance, incretin. And so you could imagine that when that becomes clinically available, a person would come in with hyperglycemia, which is the presenting state, hyperglycemia, but hyperglycemia can be caused by many different things. You have a genetic predictor already in the person's medical record because everybody's genomic information will be there, and that gives you some hint of the potential kind of diabetes that might develop. Is this a beta cell deficiency type 2 diabetes, or is it more of an insulin resistant, or is it going to be an obesity mediated? And then at that point, we may want to add things like a C-peptide, for example, that tells you some sense of beta cell function. And then all that would tell you, well, you're going to have this type of diabetes, meaning that the therapy for you is X. Maybe it's a GLP-1 based therapy. Maybe it's a sulfonylurea because of the particular type. Maybe it is an insulin sensitizer. And then maybe the complications we expect you to see are going to be these at these intervals. And so maybe we don't need to check your albumin in the urine every year because it's unlikely you're going to get that. But we need to look at your fundi on a yearly basis. So that is kind of the thought.
Those genetic predictors may not only relate to the etiology of the diabetes or maybe it's the therapeutic direction that the clinician should head, but also complications of diabetes.
Absolutely.
So let's return to the comparison of classic type 1, where the HLA locus is incredibly important, but there are other genes like the insulin gene and other that are modifiers. In my opinion, and this is simply my opinion, you could be critical of it for sure, is that we know a fair amount about the genetics for type 1, but we certainly don't know the environmental influences.
Yes.
So how does precision diabetes medicine fit into that space for type 1?
Yeah, I think type 1 is a very unique and special case. I think because the therapy for type 1, once it's completely established, stage 3 type 1, meaning no beta cells left, it's insulin, there's not a whole lot of pharmacogenetic decisions that one has to make from a genetic, because at that point it's insulin or nothing. We have no other, maybe it's a different, administration of insulin, etc. But that's more of a patient preference type of decision, not a biologically based decision. So I think that the impact of precision medicine in type 1 diabetes will be more when we are ready to prevent it. When we have a high-risk person based on family history, we do that genetic profile, and then that genetic profile maybe informs the type of immune modulator that will prevent the autoimmune destruction process. But that is, we need to have those tools. We don't have them. I mean, teplizumab is very much in the early stages, but we need to have many different immune modulators that allow us to arrest the autoimmune process before it completely destroys the beta cell complement.
But it seems to me, as my question tried to direct, and maybe I was not totally clear, is the environmental influences. Right. And that's a big space, isn't it? And there's so many things that have been implicated in terms of cow's milk and wheat germ and other things. Your thought about that unanswered question about the environmental influence?
No, yeah. I mean, what I was talking about is that the role that the precision medicine might play early on in terms of the genetic profile that predisposes you to then be vulnerable to whatever environmental insult is. The environment is so broad and so difficult to harness that it's been very, very challenging. I think that the secret may come in those areas where you have, for example, in Finland, where on either side of the Finland-Russia border, you have a similar population with widely divergent risks of type 1 diabetes, where in Finland you have a much higher risk than on the Russian side. And so there has to be clues about what happened there when an artificial border was established that maybe led to different lifestyles on either side of the border based on economic systems, etc. And then maybe there's some hint there. But in the meantime, what we're left with is the person's genetic profile, the immune genes that get activated in many different types of type 1 diabetes. And once we are able to develop a drug that harnesses them, we might be able to prevent the autoimmune process regardless of what the environmental insult might be.
Well, maybe in terms of a public message, we need to kind of modify our great desire to cure diabetes, either type 1 or type 2, and really get at this polygenic nature of the disorder and work towards a cure based on the additional information we're getting. Your thoughts about misinforming the public a little bit that a cure is around the corner. It's not close at this point as far as we can tell, right?
Well, I have high hopes, Bob. I have high hopes because for the first time, with bariatric surgery, and now with most weight-inducing incretin medications like tirzepatide and others, we're getting to the point that we achieve diabetes remission. I went into endocrinology, and once I got a patient with type 2 diabetes, I was their doctor for life. Their doctor for life. But recently, I've been able to graduate people from my clinic. I don't need to see you anymore. Your A1C is 6. We're done because you've lost all this weight. And so that can give us some clues as to what might be able to use as a therapy that is a disease-modifying therapy, not just a glycemic treating therapy. And so I'm hoping that the genetics will give us some ideas as to what are the potential targets that one might find to modify the disease course. So I'm hopeful on that respect.
But that statement really relates to the epidemiology of type 2 diabetes, which is really predominant in the overweight and the obese community, right? So correcting their excess body fat really is curative in some circumstances, at least for at least 5 years after surgery and or GLP-1 receptor agonists. We don't have long-term data there. But ultimately, in terms of etiology, I think we're still in a black box a little bit, correct?
A little bit on a black box, but I think we have enough genetic information, uncovered about 50% of the genetic risk for type 2 diabetes. So we have a lot of genetic information that can be mined in an intelligent manner to say what are the things that are really pathogenic, really etiological, in terms of putting somebody on a course to beta cell degeneration and hyperglycemia. And then that opens once those pathways are found, what are the targets that could be harnessed to then develop a therapeutic that is not a glycemic treating therapeutic, but a disease modifying therapeutic. So I am hopeful that in the next 5 to 10 years, we'll have major advances because we have seen it empirically with bariatric surgery and some of the GLP-1s that one can achieve diabetes remission. So there have to be ways in which we can find new targets and new drugs that will do that.
Well, it's been great having this conversation with you, Jose. I can't thank Dr. Florez enough for being part of the Cardiometabolic Health Congress here this year. And I'm hopeful that the audience who's here and those who participate online to learn what they haven't learned because they weren't here have benefited from Dr. Florez's presence. Thank you again, Jose.
Thank you. Thank you very much.
Goodbye, everyone.